Hey, future clinicians. So today we are talking about asthma under BNF Chapter 3, Part 1. This is our short note today, so watch the video till the end. You can refresh what you have studied and learn something new from this. Now, let's begin slowly and clearly. Asthma is a very common chronic inflammatory condition of the airways. This means the airways are constantly in an inflamed state, even when the patient feels okay. There are two key features you must always remember. First, airway hyperresponsiveness. Second, variable airflow obstruction. What does that actually mean? Airways in asthma patients react very easily. Even small triggers like dust, cold air, or exercise can cause narrowing. And this narrowing is variable, sometimes mild, sometimes severe, sometimes completely normal in between. Because of this, patients develop symptoms like cough, wheeze, chest tightness, and breathlessness. Now, very important, these symptoms are not constant. They change over time and they change in intensity. Sometimes symptoms worsen slowly and sometimes they worsen suddenly. When things get worse, this leads to what we call an acute asthma attack. And in severe cases, the patient may even need hospitalization. Now, there is something called asthma COPD overlap. This is when a patient has persistent airflow limitation with features of both asthma and chronic obstructive pulmonary disease. Next, let's understand the aims of treatment. The main goal is very simple: achieve complete control. But what does complete control actually mean? It means no daytime symptoms, no nighttime awakening, no asthma attacks, no need for rescue medication, no activity limitation, normal exercise ability. And from a lung function perspective, forced expiratory volume in 1 second more than 80% predicted, or peak expiratory flow more than 80%. Also, we want minimal side effects, but in real life, patients often balance three things: symptom control, side effects, and convenience. Now, let's talk about lifestyle changes. Weight is important. If the patient is overweight, weight loss improves asthma control. Smoking is extremely dangerous, not only for the patient, but also for children exposed to smoke. So we must always advise stopping and offer support. Breathing exercises can also help. These are physiotherapy-based, sometimes audio-visual guided. They improve quality of life and reduce symptoms. Now, the most important concept: management principles. Asthma is treated using a stepwise approach. We start at the appropriate level, aim for early control, maintain that control, and then adjust treatment. If asthma is uncontrolled, we step up. If controlled, we step down. But before changing treatment, always check 4 things: correct diagnosis, adherence, inhaler technique, trigger factors. Never skip this step. Now, every patient should have a self-management program. This includes a written, personalized action plan, education, and involvement of family or carers. And importantly, regular review by a healthcare professional. Now let's move into adult management. Guidelines differ slightly. NICE uses 17 years, BTS Sign uses 12 years. Step 1, intermittent reliever. We start with an inhaled short-acting beta-2 agonist. Examples: salbutamol, terbutaline, used only when needed. In mild asthma, this alone may be enough. But here is a warning sign. If a patient uses 1 inhaler per month, that means poor control and needs urgent reassessment. Step 2, regular preventer, inhaled corticosteroid. Start a low-dose inhaled corticosteroid if short-acting beta-2 agonist used 3 or more times per week, symptoms 3 or more times per week, night waking once or more per week, or if there was an asthma attack in the last 2 years. Inhaled corticosteroid is usually taken twice daily, but can be once daily if controlled. Always use the lowest effective dose, and inhalers should be prescribed by brand. Step 3, initial add-on. According to NICE, add a leukotriene receptor antagonist, example, montelukast. Review after 4 to 8 weeks. BTS Sign suggests an alternative: add a long-acting beta-2 agonist. Examples, someterol, formoterol. Long-acting beta-2 agonist must never be used alone, always combined with inhaled corticosteroid. It can be given as a fixed-dose combination inhaler or a maintenance and reliever therapy regimen. Now, maintenance and reliever therapy is very important. It uses inhaled corticosteroid plus long-acting beta-2 agonist called formoterol in a single inhaler used for both maintenance and relief. Step 4, additional controllers. If still uncontrolled, add long-acting beta-2 agonist plus inhaled corticosteroid plus leukotriene receptor antagonist, then decide whether to continue leukotriene receptor antagonist based on response. If still uncontrolled, switch to maintenance and reliever therapy. If still uncontrolled, increase inhaled corticosteroid to moderate dose. If still uncontrolled, options include high-dose inhaled corticosteroid, add long-acting muscarinic antagonists such as tiotropium, modified release theophylline, or refer to a specialist management. In severe asthma, use regular oral corticosteroids such as prednisolone. Biologic therapies include omalizumab, mepolizumab, benralizumab, reslizumab, dupilumab. Sometimes methotrexate may be used, but it is unlicensed. Now, let's briefly cover children. For children over 5 years, Step 1, short-acting beta-2 agonist. Step 2, low-dose inhaled corticosteroid. Step 3, add leukotriene receptor antagonist. If needed, long-acting beta-2 agonist can be added, especially above 12 years. Options include fixed inhaled corticosteroid plus long-acting beta-2 agonist or maintenance and reliever therapy. If still uncontrolled, increase inhaled corticosteroid dose or refer to specialist. For children under 5 years, start with short-acting beta-2 agonist, then an 8-week trial of moderate dose inhaled corticosteroid. If no improvement, consider another diagnosis. If improvement, but relapse within 4 weeks, restart low-dose inhaled corticosteroid. If relapse after 4 weeks, repeat the trial. Alternative, leukotriene receptor antagonist. If still uncontrolled, inhaled corticosteroid plus leukotriene receptor antagonist. If still uncontrolled, stop leukotriene receptor antagonist and refer. Now, decreasing treatment. After at least 3 months of good control, reduce dose slowly, about 25 to 50%. Always maintain the lowest effective inhaled corticosteroid dose. Stop inhaled corticosteroid only if the patient is completely symptom-free. Now, exercise-induced asthma usually indicates poor control. Best treatment, use short-acting beta-2 agonist before exercise. Other options, long-acting beta-2 agonist, leukotriene receptor antagonist, sodium chromoglycate, netochromyl, theophylline. Now, pregnancy. Asthma must be well controlled. Safe drugs include short-acting beta-2 agonist, long-acting beta-2 agonist, inhaled corticosteroid, oral corticosteroids, theophylline, chromoglycate. Leukotriene receptor antagonist has limited data, but do not withhold if needed. And always advise stop smoking. Now, acute asthma. This is a sudden worsening of symptoms, breathlessness, wheeze, cough, chest tightness, with reduced peak expiratory flow or forced expiratory volume in 1 second. Most attacks develop over more than 6 hours. In children, often triggered by viral infections. Acute management in adults. First, give oxygen to maintain oxygen saturation 94 to 98%. Then, high-dose short-acting beta-2 agonist, mild cases, inhaler plus spacer. Severe, oxygen-driven nebulizer. If poor response, continuous nebulization. Give steroids, oral prednisolone, or intravenous hydrocortisone, or intramuscular methylprednisolone. Add ipratropium. In severe cases, intravenous magnesium sulfate. Last option, intravenous aminophylline. Acute management in children, oxygen first, then short-acting beta-2 agonist. Severe cases, nebulizer. Give oral prednisolone for 3 days. Add ipratropium. If severe, intravenous magnesium, intravenous salbutamol, aminophylline. Children under 2 years, always hospital management. Finally, follow-up. Check inhaler technique, review treatment, identify triggers, provide a written action plan, follow up with general practitioner within 2 days. Severe cases need specialist follow-up up to 1 year. So that is the full treatment overview of asthma. If this helped you, make sure to like, share, and subscribe so you don't miss the next lesson. In the next video, we will cover chronic obstructive pulmonary disease. See you in the next class.